A very good evening, everyone. On behalf of Swasth Wellbeing, would like to welcome you all for our today's session on promoting health in times of COVID-19 and future pandemics by Dr. Amitav Banerjee, Professor and Head Community Medicine at Dr. D.Y. Patil Medical College, Pune. So, coming to his qualification, academic qualification, he completed his MBBS from Government Medical College, Jabalpur University in the year of 1977. Post that, he went on to do his MD PSM from FMC Pune University in 1987. Then he went ahead and did his postdoctoral clinical epidemiology in International Clinical Epidemiology Network, King George Medical College, Lucknow, 1994 to 1999. To coming back to his professional experience, he served in Indian Armed Forces from 1978 to 2005. After taking premature retirement from the armed forces in 2005, he was working as professor and subsequently as head of Department of Community Medicine, Dr. D.Y. Patil Medical College, Pune. Some of his achievements include Chief of Army Staff Gold Medal for Best Paper, Impact of Information Technology on Armed Forces in the year 1996, while serving as instructor at Officers Training School, Lucknow. Director General Armed Forces Medical Services Award for Best Paper on Tribal Malaria in the year 2003 while serving at FMC Pune. Best Published Paper Award Medical Journal Armed Forces in India for Outbreak Investigation of Viral Hepatitis E in the year 2005 while serving at FMC Pune. He published more than 100 papers in peer-reviewed national and international journals and undertaken a number of funded research projects. He is a reviewer for a number of reputed international journals such as the Oxford Group of Journals, Vaccine, and the prestigious British Medical Journal. He is editor-in-chief Medical Journal D.Y. Patil University, Pune. He has also delivered keynote addresses in national and international conferences in India and abroad. In research and publication advisor, Surinder Rajabhat University, Thailand. One of his published papers on population and samples is being used as reading material in one of the research method courses being conducted at Stanford University. The same can be accessed from website of the course at Stanford University. Awarded Publons Peer Review Award 2017 as one of the top 1% peer reviewers globally. Global rank 68, Indian rank 6. So firstly, heartiest welcome, Dr. Amitav, and we feel fortunate to have you amongst us today, and thus without further delay, would like to hear it from you, sir.
Thank you, Amartya, for that wonderful introduction. It's a great privilege, pleasure, and honor to come on this platform of Swasth well-being. And it is very appropriate, actually. I am going to talk of health promotion, and this is a perfect platform. And through this platform, I think it will reach the correct target audience. And basically, what I would be going beyond this current pandemic, because this is just one virus out of possible thousands of viruses which have come and which will come in the future. So we should have some broad perspective against broad defense. We should, this is just a one tiny enemy. So if we have a health promotion, and I would just try to demonstrate whatever I will be talking, I will try to support with the data as far as possible, because we talk of evidence-based medicine. We should also talk of evidence-based public health and evidence-based public health practice. So from the data, I would like to put forth the case for health promotion. And health promotion is a way of, there are 3 tiers of prevention. In public health, conventionally, there are 3 tiers of prevention. The primary prevention, secondary prevention, and tertiary prevention. Primary prevention is before you get a disease, before the disease agent enters your body. In primary prevention, there are 2 strategies. One is health promotion. Basically, this is the talk today. Health promotion is non-specific. It is having overall good health for any future challenges, and it gives you defense against number of disease entities, be it non-communicable disease, and the present pandemic has brought to focus that this lifestyle and diet and other health promotion measures gives you protection from communicable disease also, severity and death and hospitalization. This is the day. And the second type of primary prevention is specific protection. Specific protection is one thing against one disease. That is given, the best example is a vaccine against a specific disease. So in the present pandemic, vaccine against COVID is specific protection. But that will only protect you from one disease. That doesn't give you a broad spectrum of protection. And unfortunately, as we are seeing, as the data is unfolding, it is not giving even protection from coronavirus also, because as you are well aware that the virus keeps mutating, and as you are well aware the immunity is waning. So we will see from the data that this can only be a supportive measure. It cannot be the measure for protection. So we have to ultimately fall back on health promotion. And then, of course, the secondary tier of prevention is the secondary prevention, the second tier. Secondary prevention is related to the early diagnosis and treatment. So in the context of the current pandemic, you should be able to early find the warning signs. Like you see SpO2 is coming down, a person is feeling breathless or fever, or so that they get the treatment and to prevent the more severe disease. And also, in this context, I would also say this pandemic, the data has brought out that there are certain risk factors which makes a person more vulnerable to severe disease, death, and hospitalization. Those are the comorbidities, diabetes, hypertensive, with other obesity. So these can also be incorporated in the secondary prevention strategies, that you identify people with these risk factors and try to control them so that they are less vulnerable to COVID. And of course, tertiary prevention is that person who has recovered. That person may be having long-term symptoms. Of course, there is an entity which is not very well defined, that is long COVID. So one should not stress too much on that, because until unless we know everything about it, it can cause psychological problems. But we are very well aware now that this lockdown, loss of business, loss of school and other things have caused a lot of psychological and social trauma. So these mental health problems will be the long term. We have to look into it to tertiary prevention, that how to rehabilitate those people who have lost their jobs, how to rehabilitate the people who have lost their education, bring them back in the mainstream. So in this context, I am more concerned about the other ill effects of the whatever restrictive measures, that we have to rehabilitate the people who have lost their job, who have lost their education. Long COVID is just also one thing, but that I don't say that it should get so much priority, because the other ill effects are more. And of course, long COVID, we don't know, because we are hardly, we have any time, because it would be very difficult to identify what is long COVID, because people get so many, subsequently large cohort, almost 80-90%, 100% Indians have encountered the virus as per zero surveys. So whatever future disease a person gets, he or she may attribute it to COVID infection. So that will be not scientifically very correct. So there is no way in which we can identify what is long COVID. Actually, it's a very abstract thing as on today. So anyway, I would just like to give a short presentation. I would like to share the screen. I will just use this screen share. And I would just like to share a short presentation. And then I would like to give some very interesting data I have got. So this is the topic, as we have discussed, promoting health in times of COVID-19 and future pandemics. So this approach, I would like to go by the epidemiological approach, which we ask very simple questions. First is, what is the event magnitude? Magnitude we will measure by the deaths per million in different countries. I would like to give an overview of the impact of the pandemic as measured by the deaths per million in the Northern Hemisphere and the Asian and African continents. And that will be the measure of the impact, because each country has got different population. So deaths per million standardizes the comparison. Then who are getting affected? As we have already seen by now, that it is the people who are aged with comorbidities, who are obese, they are likely to have severe disease. And I will be presenting comparative data where the pattern of obesity and age are the deciding factor of the impact as evident from the data. Where, when and why. Where, when and why would be, I would be trying to give the different geographical distribution patterns. And the flowing from the data, we'll be asking the question what can be done for future prevention and how to prevent in future and what can be the difficulties. So basically, as I said, these are the things which we know 2 years into the pandemic. We know uncontrolled hypertension and uncontrolled diabetes, renal disease, obesity. These are the major. Besides that, other comorbidities also, malignancies, leukemias, in children, Down syndrome or other endocrine disorders, type 1 diabetes also have been shown to be associated with severe outcomes. So this is the first slide. I have presented few countries in this. If you see the top brown color are the Western Hemisphere. First is USA, UK, Sweden, Brazil. The first column and the second white is the some Asian countries, India, Pakistan, Japan, and the last three are the African countries, Nigeria, Tanzania, and South Africa. I have just I have taken some countries so that not to clutter the PowerPoint, but we have been trying to tabulate for almost 180 countries. We tabulated this data and we found a definite pattern. When we compare the first column after the country column is the deaths per million. We have the first column is in May 2020. As I said, we have been trying to follow this throughout the pandemic. May 2020, we find the Western Hemisphere, USA, UK, Sweden, and Brazil, almost 3 digits per million compared to Asian countries, which was just a single digit, and African countries were in decimal places per million when the pandemic was just new in the cumulative deaths. Of course, Brazil had a very low mortality 10, but still higher than the India, Pakistan, and African countries. But the Sweden also, UK and USA, and most of the countries in the West had this 3 digit. Brazil started with 10, but next column after that is the recent figure, cumulative deaths per million over the 2 years as on 17th February, just 4 days ago, 2022. So you see these countries are all in 4 digits, Western Hemisphere, whereas India, Pakistan and Japan are in 3 digits. And Nigeria, Tanzania, the African countries are in 2 digits. You see the difference which we started with last year. After 1.5 years, still we are having the same gap. And except for South Africa, which is in 4 digits. And what is most interesting now is the next column. You see the median age. It is of course well known that the Western countries have got a higher age. So naturally the mortality is high there. The median is around 40. Except for Brazil, which is 30, and whereas the Asian countries, except for Japan age is 48. It is even older than the European countries. And of course, African countries are again younger. So this is one explanation. However, there are two countries which stand out, which gives you a hint on the other factors. That is the Japan. Japan is, in spite of being a very most aged population in the world, it is overweight is just, and the fourth column is most interesting. That is the overweight percentage. This is also from the WHO side. That is the percentage of people with BMI, body mass index, above 25, which is taken internationally as the measure of overweight. So more than 60% of people in the Western Hemisphere, you see almost 60% of people are overweight, compared to just 20% in the Asian and African countries, except for South Africa. South Africa, the overweight is almost 53%, almost tending towards the Western. And you see the overweight explains the South African data also of 4-digit mortality, compared higher than the other African countries and Asian countries. And similarly in Asian countries, the Japan, even being the oldest, have a very low overweight person, just like any 20s may. So this is also having a very protective effort. So this the conclusion from this comparison is that the obesity is a bigger driving factor for severe disease and particular death even then more than the age. And the last column is the vaccination coverage. You see this vaccination coverage, the Western countries are more than 70% vaccinated and still they are having the high mortality. You see, all the Western countries are having, and of course I have not put Israel. Israel is having the fourth dose and still it has got a high mortality. And if you see the African countries are having hardly 2-3%, even South Africa is 30% highest in the African and still the highest mortality in the African continent, but lower mortality than the Western continent. And similarly, other countries, the Pakistan is having just 43, but it is still lower than even India. 131, India is 364. What this drives home the point is, as I was saying, the specific protection in primary prevention, the specific protection in the vaccine is not having as much impact on the control of the pandemic or prevention of the pandemic as your overweight. Of course, age you cannot change, but weight you can control. And this weight is basically per se, obesity is a risk factor for severe disease, viral disease, coronavirus disease, because they have done studies and found the virus as a affinity for fat cells, firstly. Secondly, the obesity compromises the lung function because the respiratory muscles, they don't function well because of the fat cells. And thirdly, obesity can be a co-marker, surrogate marker of other comorbidities like diabetes and hypertension and heart disease. So this is the, I have for comparison, I have put some countries. Subsequently, 3 slides, I will be putting more countries and the same pattern comes out. These are the Western countries. So you see, again, more countries, I have included Sweden and Belarus also. Sweden, Belarus, because Sweden and Belarus are the two countries in the northern hemisphere which did not have the restrictive measures like lockdown and mask mandates. And if you see, Sweden is lower compared to the death per million, particularly in the February 2022, cumulative death per million is more or less less, and Belarus also less compared to countries. So this is the same pattern in 4 digits. Most of the countries are having 4 digits. These are Western countries as on February 2022. And the obesity is also 60%. All the European countries, the Western hemisphere has become obese. And Brazil also, I was telling the Brazil has a younger age, but it has got a high obesity is almost 57. That is almost 60% touching the rate of the Western countries, and it has got a high mortality. So this is a driving factor more than age, it is the obesity. Similarly, here if you see, again, these are the Asian countries. This was the present figure is again, if you see here, and Sri Lanka is also having very high. It is very interesting. I have not put it, but after the vaccine, Sri Lanka was having much less than India, but now it is having much less, 737 compared to India's 364 million. So this started after the vaccine rollout, otherwise Sri Lanka. So again the question comes ki whether, and it has got a higher vaccination rate than India. It is 64%, India is 56%, but still it is higher, almost double than India. So vaccination coverage at the population level, at least it is not making as much impact as we expected, and it has been a great disappointment for the world. Bangladesh, if you see, just 173, and the vaccination coverage is just 37. India is 56, 37, and still it is there. Less, much less. Similarly, if you see, I have not said Pakistan. Pakistan is also 43% vaccination coverage and 131, almost one-third the Indian rate. So vaccination coverage do not correlate very well, except for Japan. Japan is having a higher vaccination rate, but that is incidental. And one thing interesting about Japan is that they have never had vaccine mandates, and they never had lockdown also. So they communicated to the people the pros and cons of vaccination, the side effects of vaccination, and they did not do any discrimination. Like in the most countries, you are not allowed to go to school, malls, and other things. Japan does not have any of that, and the vaccine uptake is higher there. That means the people, if you are honest with the people, the people cooperate with you. This is the African countries. African countries, again, very low vaccination rate, except for South Africa. In Africa, if you see the continent, maximum 30%, 10 times more vaccination. And Egypt is also having, and Egypt is number 2 in Africa. Highest is South Africa, 1611, with a vaccination coverage of 30%. And other South African countries have less than 2%, 1%, except for Egypt. Egypt has got a high vaccination coverage compared to other African, and it has got 3 digit. And of course, because Egypt is also very obese. You see, obesity is 63.5, the fourth column. And South Africa is all 53. So this obesity is double than the other African countries. And of course, South Africa has got much higher than Egypt because there are other factors like population density and other things, the urbanization. So those may be the other factors. But there is a tendency with obesity, it increases the mortality, and with vaccination, it has a modest or no effect. So these are the take-home messages from this data. Throughout the pandemic, the Western countries had to 5 to 10 times higher mortality from COVID-19 compared to African and Asian countries with few outliers. What were the two outliers? Japan was an outlier and Brazil was an outlier. Age and more important, obesity as measured by body mass index was strong predictors of this difference irrespective of vaccination coverage. Age, of course, as I said, we cannot change, but we can control our obesity by health promotion. We will be coming to health promotion. Japan, Brazil and South Africa, outliers in each continent, further establishes this point. In spite of higher age, lower obesity acted as protective in Japan. Opposite was the case in Brazil. Brazil have a younger age but high obesity. Japan has an older age but low obesity. Obesity per se reduces lung function and also surrogate marker of other comorbidities like diabetes, hypertension, heart disease. They say if you control your obesity, you also simultaneously control your diabetes, you control your hypertension, your medication of diabetes reduces, your medication of hypertension reduces, your heart disease risk reduces. All these are related to lifestyle factors like physical activity, diet, tobacco, alcohol, stress, and studies so can explain. There have been published studies which show that if you control your weight, obesity, if you control your anxiety, you get 70% protection from the adverse effects of severe coronavirus or other viral diseases. So that is as good as vaccine. And the advantage of this is your promotion of healthy lifestyle is that vaccine loses the efficacy. Vaccine cannot work when there is a mutation or variants. But your health and your control of obesity or fitness will efficacy will not go down with time, and also it will with mutation it will continue to work against the mutants also. So this is the just a quiz in between. Who is he? So how what do we conclude? So this was the great philosopher, mathematician, philosopher, Nobel Prize winner Bertrand Russell. Bertrand Russell in one of his essays said that man is struggling, we may say humans now, being gender sensitive. What he mentioned was Nobel laureate 3 stages, that man has passed through 3 stages of conflict. He says first man was fighting nature, which we may include these infections and zoonosis from animal infections and other things or other environments uh, as the first year. Once he conquers this communicable disease or other hazards of nature, man fights man. There are violence, homicide, wars. Man kills man. As we see, we have got more non-com. Then, lastly, when he has vanquished his enemy, like now we have got a unipolar world. Earlier, the USA, the two major powers used to fight with each other. Now we have got a unipower. So man is idle and man indulges into bad habits like misuse of alcohol, misuse of tobacco, drug addiction. So man becomes his own enemy. So the lifestyle factors are man becomes the own enemy. So that is we have reached that stage that with the affluence our lifestyle is changing. But there is one thing, had he been alive he would have realized that these are just cycles, because again we are going back to assault by humans on environment, because we are encroaching on the environment, there is deforestation. So there is again the environment is also attacking us again. So again there are animal borne diseases from the interface between man and animal. There is ecological imbalance, there is global warming, so the vectors, so forest cover, habitat reduced. So more than 70% of emerging diseases are of animal origin. Even this is supposed to be, of course there is a controversy now whether it is a lab or animal. So whatever it is, this coronaviruses are prevalent in the animal kingdom. So back to stage one. Again, the man is struggling with environment. So again, I would like to bring to here that first, initially I said that we should not tackle one disease piecemeal. That is, if you win like a game of chess in public health, we have to see all the whole board. On the whole board, what is happening now, we are playing like a beginner, or the world medical community is just chasing one virus, that is the coronavirus. But it is like a grandmaster does not play only with the queen. Grandmaster sees the other pieces also. Sometimes the other pieces may have the loss of other pieces may lose the game even if you can protect the queen. So, as I said, in public health policy making, similarly, whether it is at an individual level or at a population level, individual level you have to see overall health, not only the vaccine. Vaccine is just the one piece, that is the queen. But if your other pieces are weak, even if you have the vaccine, you will succumb or you will get severe disease if you have got poor health. They have done studies now to show that if your health is poor, even your antibody response to vaccination is also poor. Even vaccination doesn't work if in a person who has vitamin D deficiency, because vitamin D levels are also related with the healthy lifestyle, as we will see. So epidemiology, as an epidemiologist, we see all the pieces. Like a grandmaster sees all the pieces. So we see other diseases. We see the association of other factors. Like a grandmaster sees where the pieces are same, the chessboard is same, but the arrangement of the pieces. So each game of chess is different. So similarly, each country is different. Each in the country also, each state may be different, each region may be different. So this is the way it is. So like a good grandmaster, we have to see all the all the pieces, and then only we can accordingly plan a strategy. What has been happening is one size fits all, put vaccine to everyone, put lockdown to everyone. That's why we are in this mess. So corona is queen, but other pieces matter too. How do we see that? We have to compare. We are a country where the coronavirus is not the only disease. It may be in the West. For them, it is the only communicable disease. So they have gone into a overdrive. But in our country, all the other communicable diseases, tropical diseases, are having much higher mortality. So we have to balance the other pieces also. So these are we will compare the lethality of the coronavirus with other diseases. So this is the lethality of the coronavirus. Up to 19 years, if the person gets infected, and this is done from the sero surveys that 90 crore Indian got infected, antibodies by antibodies, and how many died. So up to 19 years, survival from 25 studies, pooled studies, the survival rate is 99.9973. मतलब almost 99.9973 young people up below 19 years, they survive after getting infected. The mortality is less than 0.001. Whereas up to the age of 69 years, the survival is 99.4, so almost 99.5. So at the age of 69 years, I am 68 years, there any other disease I get, the survival mortality can be 5%, 10%. You are exposed to so many risks in life as you age. So this, if you see in this perspective, it should just going after 1 year at the neglect of other diseases will not improve overall health. In fact, the resources diverted from the other more lethal diseases will bring down the population health. And after 70 years, the mortality is 3 to 5%. If the person is very frail in nursing home, in fact, in Italy and England, the median age of death in the first wave was 80 years. So those are very old people. So we cannot extrapolate that data to a younger population in Asian and African countries. So in those 80-year plus or 70-year plus who are in nursing homes, who are bedridden, they have done studies. This John Ioannidis from Stanford University only have published a study where they have found even the common cold virus kills 8% 5% of people who are very old and who are bedridden. Even any viral pneumonia can kill. So coronavirus, that way it may not. If you take it in perspective, there are other diseases, particularly in our country. These are the survival rate. That was the this is the mortality rate, infection fatality rate. That was the survival rate. So that is the reciprocal of this. So this is the infection fatality rate is young people is just 2 in 1 million people die in 1 million. So that is much higher than road traffic accidents also. Every day we have faced 400, 500 young people die of road traffic accidents in India. As I said, up to the age of 69 years, the almost 0.6% is the fatality rate, infection fatality rate. So it is a very low compared to, now we compare to our other disease burdens. Road traffic accidents kills 415 deaths per day and 3 times crippled, 70% in young people. So you see every day young children, about 300 young children die of road traffic accidents, and 3 times, matlab almost 1000 are having crippled for life. So this is road traffic accidents. We are not stopping automobiles. Every day 300 young people are dying. Here we have closed schools where hardly any child has died. Typhoid, the fatality after treatment also is 1 to 4% because we have got drug resistant typhoid. So fatality among untreated is 10 to 30%. Vaccine is available for typhoid, but coverage is not there. Typhoid is a more serious disease in our country than COVID because it kills young people. It kills healthy people, young people, and missed typhoid. If the health services are not there, missed typhoid, the mortality is 10 to 30%. Similarly, dengue, we have got a periodic, every year we have got outbreaks of dengue in large parts of the country. 70% global burden in Asia. And dengue hemorrhagic fever, if it is undiagnosed in time, if it is not diagnosed in time, have a mortality almost 10% to 20%. Japanese encephalitis is again a major problem in the rice belts of a country, particularly in Uttar Pradesh, in southern parts. So mortality, and it affects children below 15 years, and the vaccine is there. And the mortality is almost 50% in children, and the neurological complications are there. So mostly it's a rural disease, so it is not getting an attention probably. Scrub typhus, again, fatality is undiagnosed 30%, diagnosis 1-2%. Scrub typhus, again, in the areas where there is a post monsoons. Tuberculosis kills 1400 people every day. Tuberculosis kills almost 5 lakh Indians every year, and 1400 every day die from tuberculosis. And even for treated cases, the mortality can range anything from 5 to 20%. Imagine, after treatment, mortality is 5%, whereas in coronavirus, COVID-19, even without treatment, the survival is 99.99 in young people and 99.5 in old people. So one can imagine that even without treatment, we are surviving more from coronavirus infection compared to other diseases which are very prevalent in India. Tuberculosis is taking life of 1400 Indians and young Indians, mind you. Child deaths. From all these causes, every day 2000 children die in India, every day, from preventable diseases like diarrhea, other respiratory infections, and under a background of severe malnutrition. And the concern here is because of the economic setback of the pandemic, almost 4,000 children will die. That is the prediction from UNICEF. So as it is, even 2,000 children dying every day is really unacceptable. So here, if you see the board, we have got other. So these are the ethical issues, like we are diverting. These are the, this is by my friend Professor Bhaskar Raman from IIT Mumbai. He has sketched this. He is a professor there. So this is the dilemma, whether you want to save 1 in 1 million, 2 child die of corona, 1 in million or 2 in million may die. To save that 1 in 1 million, you have closed schools, you have done lockdown. So much other children are dying of poverty and other diseases and other setbacks. So this is the ethical dilemma which has to be resolved. So as I said, these are the health promotion requires individual efforts and discipline, but more than that, this is a social environment, so, enabling environment. In our days, when we were young, we had a lot of young people were indulging in a lot of physical activity. Cycle was our mode of transport. It was giving us physical activity. It was open air. You see, open air ventilation does not cause spread of respiratory infection. And we were getting lots of sunshine. Vitamin D has come out as an important aspect in this pandemic, that vitamin D deficiency was firstly associated with high morbidity and mortality from COVID, and secondly, vitamin D deficiency interfered with the efficacy of vaccines because the immune response depends on adequate vitamin D levels. And most of the, we have done studies, we will show you, young people nowadays are mostly invariably they are deficient in vitamin D. Then they are now mostly using sedentary two-wheelers, automated two-wheelers or cars. So they have, from the cycle they have become sedentary. And closed space in the cars will increase respiratory spread, and there is no sunlight and lack of vitamin D in the car. Similarly, the office spaces were open veranda, and nowadays it is the cubicle. So there is again entrapped air, no sunlight, no fresh air. So this is we are building up for a respiratory disease pandemic. So from time to time we should go walk out and similarly healthy meal. I am not aware of Japanese food, but I have taken this from the net because I saw the Japanese were having the least mortality in spite of oldest age. So, but I don't know much about Japanese food, but it looks quite healthy and it is quite similar to our Indian food. I think rice is there, vegetables are there, and variety of fruits are there. So I think our Indian diet, also traditional Indian diet, is also very much resembling this Asian diets. So we should try to. There is another type of primary prevention that is known as primordial prevention. So this pandemic made me understand. I will just discuss it subsequently, that the lifestyle adoption, the preventing unhealthy lifestyles coming into a population is known as primordial prevention. Before individual level, the culture changes. We are in a global world where there is a global culture, particularly the Western unhealthy diets and unhealthy habits. Here now, from the Japanese diet, we are going to the American diet with the change of McDonald's and other things. So these are the diets which are, and the combined with the lack of physical activity and the mode of transportation is making us obese. Americans are already 60% obese. We are also, or overall obesity would be less than 20%. But if you take only Indian middle classes, I think it is we are reaching the American standards. So if you see the second wave, that's why it was more severe, because it hit the middle class, which were more American in their habits and in their body mass compared to the average Indian. So India is a big country. There are many countries inside India. There is America inside India. There is Africa inside India. There is India inside India. So we have to accordingly plan and advise ourselves, advise our. Similarly, this lockdown over 2 years, they have done studies. In America, on an average, people have gained 5 kg. Some have gained 20 kg, some have gained 2 kgs, but everybody has gained weight during the lockdown periods. Even children have gained weight. So that is making you more vulnerable to the ill effects of the virus and maybe future pandemics also. So what the research shows, as I said, we had done some study which we found 4 times, the younger generation was 4 times more likely to have a deficiency of vitamin D compared to the older generation. We took the college students and we took the teachers. The college students were 4 times more deficient in vitamin D compared to the teacher. Then comorbidities, we did a survey in a field practice area, urban, rural, both. We found that India, another handicap of Indians is Indians are more prone to diabetes, a decade, and heart disease a decade or two earlier than their Caucasian counterparts because of some genetic handicap. So we develop central obesity. So we have a younger diabetics compared to Western diabetics, and most of them are 35 to 40 year age diabetics. Those who develop diabetes earlier, most of them go undetected because it's not suspected, and the early period there is no symptom. So these 50% of the diabetics and 50% of the hypertensive in the 35 to 50 years were not aware of the diabetes or the hypertension, and this can make us vulnerable to future pandemics. So health promotion, as I said, if you become obese, you tend to become diabetic, you tend to have high blood pressure. So we will be vulnerable to future pandemics. So risk factors for diabetes and non-communicable are found in younger age groups in both urban and rural samples. So these are the gradually lifestyle changes are seeping into the rural areas because high pressure marketing. And as I said, studies reported no association. They have done studies in 68 countries and almost 2,947 American counties comparing the vaccination coverage with the trends and incidence of coronavirus. They found no association between the vaccination coverage in 68 countries and the trends in, and Israel is the standing example where they are almost on the fourth dose and still having surge. So the vaccination is not a single, it is only supportive. So this is the, just to sum up now, strategies for prevention based on the patterns we have discussed. The primary prevention, as I said, we have to go one step ahead than health promotion. One step ahead than health promotion is the primordial, primordial prevention, which is the prevent our population adopting those lifestyles like Western lifestyles which lead to obesity and unhealthy profile. That can be done at young ages. Awareness of young people, college students, school students, college canteen, that is primordial prevention. And promote a culture of exercise, promote a culture of outdoor activity, promote a culture of exposure to sunshine. Then health promotion is control of obesity, control of vitamin D deficiency, and healthy diet, sleep, exercise, and freedom from anxiety. They have found anxiety disorder is also strongly associated with impaired immune system. Then specific preventions are vaccines. How much role are vaccines panacea? They are not. The data is not very encouraging. Data from 68 countries and 2947 countries are not very encouraging. Population level vaccine coverage do not seem to interrupt transmission. May have some impact on hospitalization and deaths, but duration is questionable. We don't know 3 months, 4 months you require a booster. Can we afford it? Such a large country. Honeymoon period of vaccine is over. It was initially we thought vaccine would be necessary and sufficient to stop the pandemic. Subsequently, we thought ki, okay, it is necessary but not sufficient. We require other measures also. And now we may know it may neither be necessary nor sufficient because we have got now Omicron, which is doing the work of a vaccine. So we are reaching herd immunity in the nature's way, but as I said, we have to be ready for future pandemics, not to be caught on the wrong foot. And the present pandemic, from the data, has shown those countries have the highest mortality who are obese, that who are not having good health promotion, because obesity is a quick marker of unhealthy health profile. And tertiary prevention, as I said, long COVID debatable, but psychological, social, educational, and vocational rehabilitation of victims of collateral harm. This is required long term tertiary prevention. So these are some of the references like vitamin D study we have done. Then we have done study on diabetes in the community. We have done study of risk factors for diabetes. Then this is the study of 68 countries, which is published in by European Journal of Epidemiology. Then there's a very interesting study just 3 4 days back. I just got this paper from someone. They have done a study which is published through British Journal of Sports Medicine. They have found small steps, strong seal, directly measured moderate physical activity in 65,361 adults is associated with significant protective effects from COVID-19 outcomes. So that study have followed up more than 65,000 adults and measured their daily physical activity like half an hour brisk walk or brisk running, swimming, cycling. They have said even moderate physical activity, that is say just 30 minutes walk a day, brisk walking, was related to much higher protective level from just physical activity. Even it may reduce obesity in the long run, but in the short term, even indulging in physical activity increases your immunity to this viral infection like COVID. So this is quite encouraging. So we should all try to at least do 30 minutes daily. Little sweat we should work up. Of course, consult your physician. You should do graded, and this would be very good for as a habit. And of course, consumption of healthy, they say fruits, particularly minimum 5 helpings of fruits, 70 grams each helping, also is very protective for this type of long term. So I think this is all I have with me, and we can have any questions I can take. Any points, any inputs from the?
Yes, sir. So this was a lovely session, and it was really great to hear with the references and other things from your end, sir. So if there are any questions, we will be happy to take it forward. Otherwise,
কনফারেন্স হ্যাঁ একটু মাকে করো আমি কনফারেন্সে আছি 5 মিনিট পরে
yeah, I think there are no much questions right now. So we'll conclude it. So with this, we have come to an end of today's session. Thank you for giving us your valuable time and enlightening us and our viewers with the knowledge and information about the topic. Also, I would like to thank all the participants and viewers for being part of this session. And finally, with the hope of having all on board again with us for more such informative sessions by eminent as experts. Thank you so much, Dr. Amitav, for
Thank
being
you.
here
It was
and
a pleasure.
supporting us this week.
Thank you.
Thank you. Thank you so much, sir.
Thank you.